I think in 30 seconds we'll let the students in now, and then
Good morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. We will have a Q&A session at the end, and you can ask questions in the chat box, and they will also be addressed.
good morning, everyone. Dr. Coyle, you can also your camera as well. I'm honored to introduce our mentor for today, Dr. Coyle. Dr. Coyle is an accomplished physician working in hospital medicine with MedStar St. Mary's. She attended Thomas Jefferson Medical School and completed an internal medicine residency at the University of Pittsburgh Medical Center. She completed a rheumatology fellowship at the National Institutes of Health. Prior to medical school, she served as a surgical ICU nurse practitioner. Now I'd like to request Dr. Coyle to begin today's session. Thank you.
Hi, everybody. I'm just going to put this iPad down because my capacity is limited. Can everybody hear me?
Yes.
Okay. All right. So today I'm going to talk about acute pulmonary embolism in adults. And this is just a very general overview. It's a very huge topic. I think it's an important one. I think it's it's becoming realized that it's more common than we had realized in the past. And because symptoms are often nonspecific and mortality can be quite high, it's important to maintain a high index of suspicion.
Hello.
So next slide, please.
Hello.
So the definition of pulmonary embolism is obstruction of the pulmonary artery or one of its branches by material, for example, thrombus, tumor, air, or fat that originated elsewhere in the body. And this presentation focuses on PE due to thrombus. Acute PE due to venous thromboembolism is common and sometimes fatal. Its clinical presentation is variable and often nonspecific, making the diagnosis challenging. The evaluation of patients with suspected PE should be efficient so patients can be diagnosed and therapy administered quickly to reduce associated morbidity and mortality. Next slide, please. Regarding nomenclature, PE can be classified by 1, the temporal pattern of presentation, 2, the presence or absence of hemodynamic instability, 3, the anatomic location, and 4, the presence or absence of symptoms. Regarding the temporal pattern of presentation, it can be acute or subacute, i.e. symptoms within days to weeks, or chronic. Patients develop pulmonary hypertension over years. Hemodynamically stable or unstable, a massive PE actually refers to hemodynamic effects, not necessarily the size of the PE. Hemodynamically unstable patients or massive PE present with hypotension, tachycardia, and shock. Hemodynamically stable patients, PE is referred to as submassive if associated with right ventricular strain. Next slide. As far as anatomic location, the embolus can be saddle, lobar, segmental, or subsegmental. Saddle PE lodges at the bifurcation of the main pulmonary artery in 3 to 6%. But actually only 22% of these patients are unstable. Most PEs travel beyond the bifurcation to lodge in the main lobar, segmental, or subsegmental branches of the pulmonary artery. Pulmonary emboli can be bilateral or unilateral. Next slide. And the final classification is whether the PE is symptomatic or asymptomatic, and we'll go over symptoms in a little later in the presentation. Next slide. As far as epidemiology, there's been increased detection of PEs with the event of D-dimer and computed tomography pulmonary angiography, or CTA, CTPA utilization. It's estimated that there are 112 cases per 100,000 people. This estimate was made after 1998, which is double that of prior. The incidence is higher in males, 56 versus females, 48 per 100,000. The incidence increases with age. In the United States, approximately 100,000 deaths annually occur due to pulmonary embolism, but this is a very difficult estimation as many sudden cardiac deaths occur secondary to PE. The deaths are actually declining, but the overall mortality is high. 30-day mortality is 4%, 1 year 13%. And the incidence actually varies in selected populations including patients with malignancy, those who are hospitalized, and postoperative patients. Next slide. Pathogenesis of PE is similar to that which underlies generation of thrombus. This is referred to as Virchow's triad, which encompasses venous stasis, endothelial injury, and hypercoagulable state. A risk factor for thrombus can be identified in greater than 80% of patients with venous thrombus. And this is actually independent of patients who are prone to hypercoagulability, such that 50% of PE patients with inherited thrombophilia had a PE actually associated with an actual risk factor. So you need the risk factor. You may have an underlying predisposition, but the risk factor needs to be present in order for it to occur. Next slide. Risk factors, genetic. There are greater than 50 mutations identified. Most common are factor V Leiden and the prothrombin gene mutation 2021-0A. Risk factors can be acquired, described as provoked versus non-provoked. Provoked include recent surgery, trauma, immobilization, hormone therapy, particularly the initiation of hormone therapy, active cancer, obesity, and heavy cigarette smoking. Next slide. The source of pulmonary embolism, most are thought to arise from the lower extremity proximal veins, such as the iliac, femoral, and popliteal. Greater than 50% of patients with a proximal DVT have a PE at presentation. Regarding a DVT of calf veins, 1/3 of untreated calf DVT do extend to the proximal veins where there's a greater risk of embolization, but 2/3 do resolve spontaneously. Renal and upper extremity veins can embolize. Thrombus in renal and upper extremity veins can embolize, but this is much less common. Pulmonary emboli are typically multiple, with the lower lobes involved in the majority of cases. Once the thrombus lodges, a series of pathophysiologic responses can occur. These include infarction, abnormal gas exchange and hypoxemia, cardiovascular compromise, and increased pulmonary vascular resistance. Pulmonary infarction occurs in 10%. Patients are more likely to demonstrate pleurisy and hemoptysis secondary to the intense inflammatory response in the lung, parietal, and visceral pleura. Abnormal gas exchange and hypoxemia is thought secondary to mechanical and functional obstruction to the vascular bed, altering the ventilation perfusion ratio. In addition, inflammation causes surfactant dysfunction and atelectasis, resulting in shunting. Cardiovascular compromise, patients can be hypotensive, secondary to decreased stroke volume and cardiac output. And the definition, heart rate times stroke volume equals cardiac output. When the stroke volume and cardiac output are low, the heart rate increases to compensate, which is why we see tachycardia and pulmonary embolism. Another response can be increased pulmonary vascular resistance. This leads to decreased right ventricular outflow, right ventricular dilation, decreased RV preload, and decreased cardiac output. So next slide, a little bit on clinical presentation. I'm going to go over some history and physical findings, labs, ECG findings, and chest X-ray findings. Next slide. So the PIOPED group, PIOPED stands for the Prospective Investigation of Pulmonary Embolism Diagnosis. This is a series of 3 multi-center studies. PIOPED 1 went from 1983 to 1989 to evaluate the sensitivity and specificity of ventilation perfusion versus CTA. PIOPED 2 went from 2000 to 2005. This studied the value of spiral computed tomography that was contrast enhanced in diagnosing pulmonary embolism. And the current PIOPED study, PIOPED 3, is studying gadolinium MRI of the pulmonary arteries and magnetic resonance venous imaging of the lower extremities in the diagnosis of PE. So there's been a lot of data generated from these studies. In the PIOPED group, they report that the most common symptoms of pulmonary embolism are dyspnea at rest or exertion in 73%, pleuritic pain in 66%, cough in 37%, orthopnea in 28%, calf or thigh pain and swelling in 44%, wheezing in 21%, hemoptysis in 13%. Arrhythmia, presyncope, syncope, and hemodynamic collapse has occurred in less than 10% of patients in their studies. Next slide. From PIOPED as well, the most common presenting signs on exam are tachypnea in 54%, calf or thigh swelling, erythema, tenderness, and palpable cords in 47%, tachycardia in 24%, rales in 18%, decreased breath sounds 7%, accentuated P2 in 15%, with P2 being the pulmonary component of the second heart sound on auscultation, jugular venous distension in 14%, and fever in 3%. Next slide. Regarding labs, CBC and chemistry are, the results are essentially non-specific. You can see a leukocytosis, elevated sed rate, elevated LDH, and elevated AST. Arterial blood gas shows hypoxemia in 74%, widened AA gradient in 62 to 86%, and respiratory alkalosis and hypocapnia in 41%. And this finding occurs secondary to the increased respiratory rate or tachypnea that is seen in PE often. Troponin is not useful diagnostically, and I apologize for there may be a lot of D-dimmers because it kept autocorrecting to D-dimmer as opposed to D-dimer, but we'll discuss a D-dimer a little bit later in the presentation. Next slide. On electrocardiogram, you can see atrial dysrhythmias such as atrial fibrillation or atrial flutter, bradycardia, new right bundle branch block, inferior Q waves, i.e. Q waves in 2, 3, and AVF, anterior ST changes and T wave inversion, and a finding of S1, Q3, T3, which is a presence of the S wave in lead 1 and Q waves and T wave inversion in lead 3. Next slide. Chest X-ray is normal in 12 to 22% of patients. Non-specific abnormalities are common, such as atelectasis and pleural effusion. And this is typically performed to look for alternative cause of symptoms in suspected PE as opposed to being actually diagnostic. And I apologize also, I would have loved to include pictures, but my time and my computer capacities are quite limited. So, I encourage you to look up pictures online of these findings. So on chest X-ray, if present, two things called, one, a Hampton's hump, two, Westermarck sign can raise suspicion of PE. And Hampton's hump is actually a hump-shaped pleural-based peripheral opacity on X-ray. And Westermarck sign, often you can see the pulmonary vasculature actually on the X-ray. And with Westermarck sign, there's a sharp cutoff with distal hypoperfusion. Next slide. So much of the diagnostic approach, I think I included this because I think it's important to understand the decision-making process when patients present with suspected PE. This primarily focuses on patients who are hemodynamically stable, and we have time for this approach. Obviously, somebody in cardiogenic shock, one would go directly to definitive imaging. But for hemodynamically stable patients, the diagnostic approach is preferred that you combine clinical and pre-test probability assessment with lab work and with imaging. So that would include calculating a Wells score or modified Wells score, obtaining a D-dimer level if indicated, and definitive imaging. Next slide. The Wells score encompasses the following for which different points are assigned. So for physical findings of a DVT, one assigns 3 points. If no alternative diagnosis better explains the findings, 3 points. Tachycardia greater than 100 gives you 1.5 point. Embolization for greater than or equal to 3 days or surgery within the previous 4 weeks would be assigned 1.5 points. Prior DVT or PE, 1.5 points. The presence of hemoptysis, 1 point, and the presence of malignancy, 1 point. So according to the Wells score, there's a high probability of PE for a score greater than 6, medium probability for a score between 2 and 6, and low probability for a score less than 2. The modified Wells score is also used, in which a PE is likely if the score is greater than 4, and unlikely if it's less than or equal to 4. Next slide. And so some people also, and I've seen them use this in the emergency department, it's not universally used, use something called the PERC rule or the PERC score. And this is the pulmonary embolism rule-out criteria. So this rule is only valid in patients with a low clinical probabilities of PE. So you calculate the Wells score, you have a low probability, you then go to the PERC rule. So in patients with a low probability of PE who fulfill all 8 criteria, the likelihood of PE is low and no further testing is required. All other patients should be considered for further testing with D-dimer or imaging. So these 8 criteria: age less than 50, heart rate less than 100, oxygen saturation greater than or equal to 95%, no hemoptysis, no estrogen use, no prior DVT or PE, no unilateral leg swelling, and no surgery or trauma requiring hospitalization within the prior 4 weeks. Next slide. So D-dimer is a fibrin degradation product. It's a small protein fragment found in the blood after a blood clot is degraded by fibrinolysis. It is so named because it contains 2 D fragments of the fibrin protein joined by a crosslink. I wanted to point out in this slide that just because you have an elevated D-dimer does not mean that you have a pulmonary embolism. It leads you, it is you're very useful in the diagnosis of pulmonary embolism, but there are many, many other causes, and these include thromboembolism, inflammation. We see very high levels often of D-dimer in COVID-19 and other severe infections, and sepsis. D-dimer elevation can occur in surgery and trauma, liver disease, kidney disease, vascular disorders such as sickle cell vaso-occlusion and vascular malformation, malignancy, thrombolytic therapy, and pregnancy, either normal or those with preeclampsia or eclampsia. So again, to emphasize, a D-dimer elevation is not sufficient for diagnosis. A normal D-dimer can be used to rule out PE in patients with low probability. Some people say lower intermediate, many say just low probability. And the D-dimer test is best used in conjunction with clinical probability assessment. Next slide. So in patients who are calculated to have a low risk for PE, a normal D-dimer that's subsequently performed effectively excludes PE, and typically no further testing is required. And this includes even if patients have had a prior PE and if they've been hospitalized. But if elevated further diagnostic testing is warranted. As far as patients calculated to have intermediate risk, for most intermediate risk patients, it's recommended that a normal D-dimer be thought to effectively exclude PE, and typically no further diagnostic testing is required. However, there's some opinion that an intermediate category subset should undergo imaging. And this subset would be a Wells score between 4 and 6. For patients with a high risk for PE, a normal D-dimer is not helpful for excluding the diagnosis and essentially does not need to be done. It does reduce the likelihood, but it is not sufficient. And in the PIOPED study, it was shown that actually people who had a high risk for PE, but negative D-dimer actually had a PE incidence of 5%. Next slide. Imaging essentially makes the diagnosis. Computed tomography or magnetic resonance pulmonary angiography reveals a filling defect in any branch of the pulmonary artery that becomes evident after contrast enhancement. This is diagnostic of PE. Ventilation perfusion scans can be done. These are often done when it is not feasible, either for time or by where you're performing the testing, or by a patient allergy to contrast, or by renal insufficiency. Ventilation perfusion scans can be helpful. And segmental or subsegmental perfusion defects with normal ventilation is essentially diagnostic of a pulmonary embolism. Normal or low, so their reported VQ scan reports are either low or normal probability, intermediate probability, or high probability. Intermediate probability is not useful, and further testing should be done. But a high probability scan and the probability of PE essentially confirms the diagnosis. And again, VQ scans these days are most often performed either when IV dye is contraindicated, or can be done also when CTPA is inconclusive, or with renal insufficiency. Those would be the most common reasons why we do a VQ scan in this time and day. Next slide. Performing an echocardiogram, particularly in a hemodynamically unstable patient. This can diagnose PE if there's a visualized clot in the proximal pulmonary arteries. The diagnosis can be supported by the presence of clot in the right heart or new right heart strain. 30 to 40% with pulmonary embolism have on echo increased RV size, decreased RV function, tricuspid regurgitation, and abnormal ventricular septal wall motion. So lower extremity ultrasound with Doppler, if it's positive in patients with symptoms of PE, the diagnosis of pulmonary embolism is highly suggestive. So there's useful if there's a delay in imaging. If the Doppler is positive, you just go ahead and you're going to anticoagulate anyway. And if negative and the suspicion is low or intermediate, it's generally safe not to anticoagulate immediately until imaging can be performed, i.e. if a contrast allergy or if it's a matter of testing location and capability. Next slide. The differential diagnosis of PE, CHF, pneumonia, myocardial infarction, pericarditis, COPD exacerbation, pneumothorax, vasculitis, and musculoskeletal pain. As far as treatment, it's really beyond the scope of this presentation to go into treatment. There are many variations from institution to institution, from pulmonologist to pulmonologist, from intensivist to intensivist. So this is a very generalized overview, and I'm not going to go into the various modes of anticoagulation, but anticoagulation is the mainstay. You can, in special populations, it's reasonable to consider either thrombolysis or embolectomy. These are particularly in hemodynamically unstable patients, or placement of an inferior vena cava filter, which is controversial, but it is still an option. So the presence of an inferior vena cava filter would be most useful in a patient who absolutely is intolerant of anticoagulation, i.e. patients who are predisposed to GI bleeds, et cetera, or patients with a cerebral bleed or predisposed to such. So examples of special populations that would affect the mode of treatment include patients with malignancy, pregnancy, heparin-induced thrombocytopenia, contraindication to anticoagulation, hemodynamic instability or failure of anticoagulation therapy. In that case, a thrombolytic therapy or embolectomy should be considered in appropriate patients. Next slide. Major adverse outcomes. First is recurrent thrombolism. thromboembolism. The recurrence rate is dependent on adequate therapeutic anticoagulation and the clinical nature of the embolic event, i.e. whether it's provoked or unprovoked. The cumulative rate of recurrence is reported as 8% at 6 months, 13% at 1 year, 23% at 5 years, and 30% at 10 years. And this varies among different populations. There's an entity known as chronic thromboembolic pulmonary hypertension, where pulmonary hypertension occurs due to the pulmonary artery obstruction from unresolved thromboembolic disease. This is uncommon and occurs from between 1% to 4% among survivors of acute PE. Documentation of prior acute PE is absent in up to 40%, however, and this is a leak outcome. Major adverse outcomes obviously include death. The untreated PE mortality is up to 30%. Mortality is significantly reduced with anticoagulation. Most deaths occur within 1 week due to shock and recurrent thromboembolism. Many of these deaths are due to predisposing comorbidities or multifactorial. And I just wanted to introduce, for your reference, there are severity indices that predict all-cause mortality, the most common of which is the Pulmonary Embolism Severity Index, which predict death. This is sensitive but not specific, and the Hestia criteria as well. And there are references available on request.
Thank you so much, Dr. Coyle. Really appreciate your time, and we're going to start our Q&A now.
Hi, Dr. Coyle. My name is Robin. I'm a third-year PhD student at the Johns Hopkins School of Medicine. To start off our Q&A, can you explain a little bit about how blood clots from deep vein thrombosis are linked to pulmonary embolism?
Well, essentially, the blood clots originate in the deep veins and then migrate to the pulmonary arteries. So there's a blood clot, and either as a whole clot or as part of the clot, there's an embolic embolism throughout the vasculature, and you get lodging in the pulmonary artery.
Can long-term stress or anxiety lead to an increased risk of blood clots?
I think long-term stress and anxiety can lead to pretty much anything. I don't know that that's ever been studied, but I have, well, you know, if you think about it, I would have no doubt that it is, but I have not come across anything that specifically identifies that as a risk factor.
Has COVID-19 been seen as posing a greater risk to blood clotting and pulmonary?
Yes, absolutely. Yes, there's a significantly increased risk of thromboembolism in patients with COVID-19. And we're still, some schools of thought are to actually fully anticoagulate patients who have, and we routinely test patients with COVID-19 for D-dimer when they're hospitalized. And there's some schools that believe that we should actually anticoagulate patients with a certain cutoff D-dimer level, but we're still obviously learning about COVID-19, and it's not a universal practice at this time.
So that was a great presentation. We'd love to ask a few general questions about what your journey through your medical
Sure.
Like. Can you tell us about your path to becoming a nurse practitioner and what it was like working in that career path?
Yeah, well, I've been working in hospitals for over 40 years now. I started out as a nursing assistant, and I went to school at the University of Pennsylvania and got my bachelor's of science in nursing there, and stayed on at Penn. I was a surgical ICU nurse for a total of 14 years. And somewhere in between there, I went back for my master's. and ended up working for a group of CT surgeons for a couple of years. I felt I really had never had any great desire to go into medicine, but I felt that my role as a nurse practitioner, I felt that I had the capacity to do what I was being asked to do, but I would be more effective if I were more highly trained, if that makes sense.
Yeah,
So I went to then I had to do 2 years of post-bac and got early acceptance to Jefferson. And I'm sorry, well, anything other specific about being a nurse practitioner or?
So within surgery, what's kind of the role of a nurse practitioner?
My role as it's defined as an acute care nurse practitioner. So basically what I did during the course of the day was I rounded on patients in the morning. I developed a plan with the surgeons. The surgeons went to the OR. I managed the patients primarily on the step down, sometimes in the intensive care, did daily orders, did daily progress notes, managed problems throughout the course of the day, and helped with discharge planning and actually discharge patients. We also saw patients in follow-up after surgery as outpatients. And for a period of time, I actually first assisted in the OR. But the role actually varies from group to group. There's no universal role of a CT surgery nurse practitioner.
So when you did go back to school to pursue medicine, what was it that motivated you to pursue internal medicine specifically?
I actually went to medical school because I was first assisting and I thought I wanted to go into surgery. I really love surgery. And right before I went to medical school, I was diagnosed with an inflammatory polyarthritis, which kind of negated going into surgery. So I'd come that far, I decided to just keep going. So I did internal medicine.
We know that as a physician, it's really important to stay up to date on all of the current research that's happening in the field. What resources do you utilize to make sure that you know all of the current treatments and disease risks that you should be looking out for?
My personal favorite is Up to Date. I think it's a wonderful, it's just a great resource. We admit, as a nighttime hospitalist, I can admit up to 12 patients a night, and I'm cross-covering patients on the floor. And if there's somebody who comes in with a problem, or even just to refresh my memory, or to make sure that I'm doing the most currently recommended therapy, I just go to Up to Date and scan through there, and it's a matter of a few minutes often. That's what I do.
So as our last question, can you explain to us a little bit what your work-life balance is like and what it's like working as a nocturnist?
I've obviously been in school for a very long time out of my life. And when I was a kid, I rode horses. So after I finished I initially did a rheumatology fellowship with the thought of going into academia, decided against that. And then actually started to have a life again. So I started to ride horses and compete. And that's basically why I work nights, so that I have a small little farm and horses, and I ride, so I get to do that during the day. So it kind of makes up for all the years of school and not really having a work-life balance.
That's great. I do the same thing. I ride with the Hopkins equestrian team, and it's like my little escape.
Oh, that's wonderful. Good for you. Good for you.
So thank you so much for your time. That's all the questions we have for you.
Okay, great.
Thank you so much, Dr. Coyle. I know that we had a couple of last minute questions just about pulmonary embolism. Again, thank you so much for sharing your journey. We really appreciate it. One was about troponin. Why wouldn't troponin be helpful to a clinical diagnosis of PE, given they can be indicative of a MI?
It's not.
Okay.
I believe that's what I said. I said troponin is not useful in the diagnosis.
Yes.
Although we actually, we can see a minor elevation in patients, but it's really not useful.
Oh, okay, got it. Thank you. And
Mhm.
which populations of patients are at greatest risk for a PE?
Patients with previous PE, patients with malignancy, and patients with a genetic predisposition.
Got it.
That's my
Thank you.
understanding.
Okay. And also about blood thinners, I know that you didn't talk about prevention because it is out of scope, but we were curious to know how long are blood thinners usually taken to reduce blood clots? And how long does it typically take for a PE to resolve?
So, as you know, blood thinners do not dissolve the clot. Blood thinners prevent clot from forming on top of the clot, and the body actually resorbs the clot itself over time. So my understanding of the current recommendation baseline is for 6 months of anticoagulation. Because of the risk of recurrence, many people extend that to either lifetime, even in patients without other risks for thromboembolism, or many patients, i.e. patients with malignancy that we discussed, very high risk patients, are often maintained on anticoagulation. I often ask patients to follow up with a hematologist so that further testing can be done so that they can actually determine their risk and know whether they should extend the anticoagulation, because I think sometimes the anticoagulation is stopped and the patient hasn't had any type of genetic workup or seen a hematologist. I think that's very useful to tell patients to do so that they can fully protect themselves.
Thank you, Dr. Coyle. And for our last question, I understand you're busy. Really appreciate you taking the time, is about comorbidities. So what are the most common comorbidities in combination with PE that may lead to an increased chance of death or a worse prognosis?
So obviously, again, patients with malignancy, patients with poor, if the patient has had a massive PE and has right ventricular strain and already has cardiovascular compromise, they're at greatest risk for morbidity and mortality. Patients with underlying lung dysfunction to begin with, again, are at increased risk because they are already so patients who are already compromised who have an additional insult, I think is the best way to look at it.
Got it. Thank you very much, Dr. Coyle. We really appreciate you taking the time to answer all of our questions and taking the time out of your day to mentor us. And I love everyone to please give a warm thank you to Dr. Coyle in the chat box for this incredibly informative session. Thank you.
Thank you very much. Have a great day, everybody.
Thank you. You too.
Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for the session is now live, and you'll need a 70% or higher to pass and receive certification. The link to the quiz is being sent in the chat now. And additionally, many of our students have expressed interest in pursuing a leadership position here at TeleShadowing. So we've reopened our leadership applications for students interested in joining our team as well. And that link is also going to be sent in the chat. And for our next session dates, these dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next session will be next Saturday, March 5th at 10 a.m. Eastern Standard Time, with our physician mentoring us in internal medicine. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.